Can we get a quick round of applause for Dean Hyman and the panelists, please? Thank you. There's been a lot written and a lot said and a lot videoed on Ebola. I don't know that anyone has done it with greater practicality, greater clarity, more succinctly than what you guys have done. So thank you. So let's take some questions from the audience. Do we have some? Yes, sir. Please.
Two questions. One is about animal transmission. Hi, Graham Wolf. I have two questions. One is about animal transmission. It's good to know that it's just bats and monkeys so far. As you know, 2 dogs were, one was euthanized in Spain, the other one was quarantined here in the United States. I'm just wondering if there's any other animals that are part of this transmission. The second question...
Let's do one at a time.
Okay.
All right? Because we've got a lot of people who are going to have questions. Let's start with one question. Who wants to take that one first?
I can take that question. So what we know is that Ebola can infect mammals. They can infect a broad spectrum of mammals. Those mammals include antelope, pigs, dogs, non-human primates, human primates. It can infect a number of animals. Now, the course of infection in those animals varies, and we don't know whether or not all animals are infectious, whether certain animals can clear virus very quickly and some can't, and some can live with it like bats without any symptoms. Now, monkeys, pigs, and humans we know are incidental hosts, that they die or have very acute symptoms when they get sick. So that's what we know. In terms of the question, I think that you bring up this question of the dogs, and that's one of the questions everybody starts wondering, well, I don't want to be near somebody who might have had Ebola or could have Ebola, because if my dog gets sick, then once somebody's dog gets sick, if people start worrying whether or not their dogs are going to get put to sleep, then we're not going to have anybody coming forward saying they've been an Ebola outbreak. And here's what we know about dogs. These dogs that were infected with Ebola were dogs that were hunting dogs, that were in contact, that were hunting these animals and eating the entrails and attacking these animals first before a hunter would go and get them. So they're going to get them the same way a human is. It's not because they were just near a human who had Ebola, and that's something very important to remember.
So I want to see if we can intermix some of the questions from the live here and the live stream. We'll get back to you. A question that came from the live stream is, how are we as individuals going to differentiate the symptoms of the flu versus Ebola?
I think a couple of things to recognize that, yes, early signs of Ebola and symptoms of Ebola may mimic that of flu, but often then flu goes on to other things like sore throats or runny nose, things like this is not classic of Ebola. But I think the main thing to realize is that if you haven't been to Sierra Leone, Guinea, or Liberia, it's not Ebola. So don't worry if you have these symptoms and you haven't had that travel history, it's not Ebola.
All right, back here, Lee Wagman.
Thank you all. That was really an
extraordinary presentation of where we are today and how we got here. I'd like to turn the telescope around and ask you to look forward and test your predictive abilities for us. Tell us where you think we'll be in the United States and our various communities here in the next 3 to 6 months.
I think maybe both, it might be interesting here internationally as well as domestically. From my own feeling of domestically, we are, as again, more and more cases occur in West Africa, and we have health workers and others going to help serve in those areas. I think we are going to be seeing that the occasional and sporadic case that may occur, but I think because of the monitoring and quarantine measures in place, we will not see transmission occurring. We've had the situation in Dallas. I think we'll have situations now that all hospitals are going to be prepared to receive, but we're not going to have all hospitals prepared to treat. And so those will be, patients will actually go to specialized care centers that really have experience using personal protective equipment and having drills and training on that. So I don't think we're going to see the transmission. But internationally is maybe a short-term pessimistic before long-term optimistic.
Let's turn it behind.
So we're going to keep going back and forth between the audience and what's online. So one of our online participants asked about whether it's possible that Ebola mutates and what happens then. And as you take that question, I actually hope you'll broaden it to speak not only about Ebola, but how we monitor influenza and other more infectious diseases, more contagious diseases that we do worry about the mutations on.
Okay, well, I can take that. I can start, and I can say that there are, of the 23 diseases that are considered, infectious diseases that are considered serious to man, there has never been a single one that has ever mutated in terms of how it infects humans. So it is very, while there, you know, if you kind of stretch your mind and you think, well, theoretically it is possible that Ebola could mutate, but we don't know how it could mutate. It could mutate to become less infectious and less virulent. And that's a more likely scenario than for it to become airborne. So I think that you know, diseases do change over time, but that takes a very long time for it to change in any major manner that could impact whether or not it is easily spread airborne as opposed to just by direct contact with bodily fluid.
Bob, before we go on, can you talk about influenza?
Yeah, and I think that Annie brings a good point about the fact that, you know, the issue of change of the type of transmission isn't happening, but the change in the virus, for example, like with influenza, we have mutations occurring. We have oftentimes a slow drift that can happen. That's one reason why you'll see vaccines year to year may change in their composition. And then once in a while, we will actually see a major shift. And that's when you can actually come up with pandemic strains like the H1N1 that we had, that is then no one has pre-existing immunity to it, and until we get vaccines made for it, you end up with large numbers of people coming down with disease.
All right, up here, John Vane, please. We've got to grab the microphone if you would. I want everybody to hear what you have to say.
Appreciate that. It seems that a big portion of this whole process is reliant on people's honesty and self-reporting of their own risks, at least people coming out of West Africa. Depending on which story you believe, it seems that we have at least one case of Mr. Duffy who did not tell the truth. So that may or may not be true, but it's like a list of scientists. What percentage of people do you think that would be coming out of West Africa are going to be honest in self-reporting? And you've already indicated that there's a more than a small chance that depending on what the reaction will be, that people will not be honest.
Well, I want to just speak very briefly to that, and then I think you have a much better perspective. But I want to say one thing about Thomas Duncan, who none of us know whether or not he knew or he didn't know. But you have to understand that this outbreak is happening at the backdrop of having one of the highest rates of child and maternal mortality in the world. People die every day of malaria, of many other things. And so the fact that you know, everybody doesn't know that they have Ebola, and it's unclear whether or not they knew that this woman was having a very standard, unfortunately standard maternal mortality event, or if it was something else. So that's the first thing to understand. The second thing, it's better the traveler you know than the traveler you don't know. And so I think we need to make it very easy for people to be able to come in and explain what their situation is before we condemn them from being somewhere. So Nancy probably has a...
So in Liberia, we have really strict protocols, and I talked about some of them around trying to make sure that someone doesn't have contact with Ebola and get infected. Before they leave Liberia, we do an assessment, and as I mentioned, we have the buddy system, so who is watching over the other person giving the treatment. We do an assessment of were there any breaches of protocol, and if there were, they don't even get on a plane to come. If there were not, then they can get on a commercial flight and come back to the States. Now, of course, with all the different requirements that are being put in place from city to city and county to county, they would be subject to whatever those requirements are. But the thing around the honesty of health workers,
That wasn't limiting it to health workers.
yeah, okay, well, right, okay. So when it comes to any time, and building on what Annie said, any time you put something in place where people have an incentive to be less than transparent, I think overall you're going to lose. There are a lot of ways to beat the system. You know, Bob talked, you know, with travel routes, et cetera, There's certain ways that you can, beat the system. There's also ways that, I remember the SARS breakout. People traveling around the world saying how they managed to sneak into their country, right? We know those stories because we heard them. So I think that any time you have something in place that is deemed to be unnecessary by the people who are facing that restriction, you are more likely to have less transparency. It's just unfortunate. And so like our health workers coming back, we are complying with every single requirement, et cetera. But for general travelers at large, it's just people have to believe that there's a good reason for something and that has to make sense, or they're going to beat the system and they're not going to believe that they're putting people at risk when they do so.
I think also, in a sense, that most of the people, what would happen if they lying, are going to be downgraded in that monitoring. So that the lowest level of monitoring, just the fact that they've been in that country, we're still going to be looking at them on a daily basis. And if they've lied about their exposure, or maybe they just didn't know about their exposure, give them credit for that, we're going to see that happen when they become symptomatic and febrile. And even because of that, we're going to be able to quickly act, so the number of people that they would end up exposing are going to be very few. And again, luckily, they're not transmissible before they are symptomatic, and probably when they're initially symptomatic, it's still very low transmission. Because we saw, the girlfriend of Mr. Duncan that he was with didn't come down with disease.
I just want to add one more thing, and it's something to think about. It's very, very difficult to recruit health workers to go to some of the countries that are difficult to work in, especially you saw the conditions in Liberia and Sierra Leone, and as was Jody, as you mentioned, the unsung heroes are the Liberians who have a lot of fear. They're living in the middle of this, and they're stepping forward to help. Some of the most courageous people you know. And the other ones are, Americans and people around the world getting on planes and traveling to Liberia and Sierra Leone. And so anything that would act as a disincentive for them, something that they would consider to be unnecessary. Reasonable people can disagree. So if you consider that there are people who feel just as strongly that a quarantine is not medically necessary and they're medical professionals, they may view that as a burden that they're not willing to accept, and therefore it can make it more difficult to recruit the very health workers we need to go to Liberia and Sierra Leone. This is one of the concerns that we have. We are very worried that people who would otherwise volunteer to serve in either country will be unwilling to go, not because they're unwilling to make that extra sacrifice, but because they don't deem it to be necessary, and therefore they don't believe it's a sacrifice that they should make. And this is our concern.
So Corey online asked, what happens if we do get into the hundreds of thousands of cases? What happens then? And as you answer that, I hope you'll also each take this moment to say, if you had one thing you could do right now to make sure we don't get to that number, what would be your highest priority?
Well,
Go ahead, please.
Go ahead.
But I was going to just simply say, in terms of the latter part of it, I think, again, a massive international mobilization. It's beginning to happen. Europe has pledged €1 billion for this. The United States, as you are well aware of, has about 4,000 military committed to build 17 hospitals, field hospitals with 100 beds each. There are a number of really outstanding organizations like the International Medical Corps that are sending physicians, nurses, and other health workers over. We just need to see that on a massive scale worldwide.
Yeah, it's the U.S. has been a leader, as Bob mentioned. Europe has followed. Qatar has jumped in. The U.S. military, but perhaps we need a scale up of dramatic proportions, and we need it as soon as possible. That's the bottom line. A number of people have said, "Is it too late?" We don't believe it's too late. We're still within that window where it can be stopped and turned back in months, not years. But we just have to move faster. There are just not enough operational efforts on the ground. It's complex work, it's difficult work, and there are a number of reasons that there are not enough efforts on the ground, but we don't have a lot of time. And this is going to require a lot more hands on deck. One of the things that we're doing is we're offering this training to other organizations, things that we've learned on case management protocols, so that people will be willing to volunteer and go over and serve. But with the clock is ticking, we're under tremendous time pressure. And the CDC and WHO and all the alarms, you know, everyone's ringing all the alarms, but everyone still believes that with current plans in place, you know, we can still get it stopped and we can turn it back before those numbers become the massive numbers that we're worried about.
I just want to add a footnote under that. So when we've been dealing with the war on terror, one of the slogans has been, let's fight it over there so we don't need to fight it here. And that's even more important with respect to this battle, which is every dollar is better spent there than it is here. And we're just so under-resourced on it. And it's a tribute to you and your organization that you're doing some of the best work over there. So to those of us that might have some political influence anyplace, God knows if any of us do, because if any of us did, I think it would be a lot better in Washington. We got to figure out how to get our political leaders to understand that imperative. Annie, to you.
So, I mean, I agree 100% with everything that both Bob and Nancy have said, but, you know, I think it's really important. It's obviously critical that we get in front of this epidemic as opposed to be chasing from behind, which is always the issue. And it's extremely important that we get this under control, but in the end, this is not the end of the story. And in fact, it's just the beginning, because next year or the year after, there'll be another disease outbreak that turns into an outbreak or an epidemic or threatens to, and it's a stark reminder of our weaknesses in our global and national health systems. And that is how we're going to be able to get in front of this epidemic and be able to prevent future ones. And that's what's very important.
Can I just add one?
Yeah, and then maybe we're going to go to Chris in the back, maybe get the mic there
All right.
for...
The health systems in these countries are so extraordinarily weak for the reasons that we discussed before. And, you know, this is a wake-up call, a real wake-up call, and an opportunity to really address it at the root.
Absolutely.
And so much of this could have been stopped earlier had there just been more health workers on the scene.
Chris Garg in the back.
Thank you. I am Chris Garg from WPO organization. First of all, thank you very much, everyone. This has been amazing. And I have to be honest, I'm left a teeny bit confused. And I think the message is very interesting. And as a marketing-oriented person, I would just point something out. There first seems to be an attempt to calm everybody's nerves, and even some jokes, you know, unless you eat a bat on Westwood Boulevard, you're not going to get Ebola. But then we also are saying simultaneously, it's getting out of hand in West Africa. We don't have enough resources. Yes, there's some troops coming, but in between the lines, we can all tell that's not going to be enough. That's not what you're looking for. You're looking for a bigger hammer. And even if the virus is growing at a smaller rate than many of these other viruses, it still can grow and it's still incredibly dangerous. So I think that my observation is, the truth of the matter is, if it isn't stopped in West Africa, it will be a global pandemic, and we will be in serious jeopardy right here on Westwood Boulevard. And I just think, you know, my observation is, a little fear is good. A little fear goes a long way. Maybe we should all be more fearful, so we can, to Leslie's point, be more supportive of, let's put many more billions, many more troops, many more resources, because it looks like it needs it. So that's, in a way, it's a question, because I'm just responding to the context of all this, that I end up going, oh great, we don't have to be that worried. Oh wow, it looks like we really do. So,
Let's have Jody address that. Well said, Chris. Thank you.
So it's a great point, because I do think we are hearing both of those, but I think there's a very good reason. So I'm glad you raised it. Let me take one swing at it and then pass it over to the panel. Both are true. So when you are sitting here in LA, how many of you, by the way, have a cell phone in your pocket or on you? Okay, even worse, how many of you have a young person in your life, a teenager or a young adult who has cell phones? Okay, So Jonathan Fielding said when this all started, and it still remains true right now, that you're at greater risk in LA of dying because somebody's texting on their phone on the 405 than from Ebola, and that is far true today. But more than that, in the United States, and this is the immense tragedy, in the United States we have 100,000 preventable deaths a year, completely preventable. If we just looked like the average of the top 3 countries in prevention, nothing perfect, 100,000 deaths from diabetes, heart disease, all sorts of things that we could utterly prevent. So if you ask the question today, is this a big risk? The answer, in LA, in the United States, the answer is the risk is teeny. There are very real risks that we can prevent. This isn't where the real risks are. The real risks are, did you get your flu shot? Don't text. Please walk home and eat something good tonight. And there are a lot of other pieces to that. At the same time, and that's why we're hosting the panel, you know, why we're so proud to be supporting the extraordinary work of the people who are here. If this were left as a wildfire out of control, then the impact where it's already devastating in West Africa, and I talked to you about what was happening in LA, but in West Africa, not just the deaths, the economic damage is already immense. But left out of control, then we will all feel it, and we will have something that is incredibly dangerous. Over to you all.
Well, I absolutely agree with what you're saying, Jody. But I think that this is really, it's true. People should be worried. Should people be fearful? I think fear makes it very difficult for people to think clearly and act appropriately. So making everybody terrified of the fact that Ebola is lurking around the corner is not necessarily the right thing. I think you have to respect the risk involved with a virus like Ebola, but to think to yourself, hey, we've had outbreaks before, and they've showed us that we're not prepared. Our global health systems have repeatedly proven themselves ineffective in identifying and responding to outbreaks and to be able to limit their spread. So this is a wake-up call. Will we likely have Ebola here in any large numbers? No. You saw the difference between the health systems in Liberia and our health systems right here. You know, there were, in 2010, I think there were 50 doctors in Liberia for 4 million people. And I think the other night I was on a panel and I learned that there were 30,000 licensed physicians in LA County. So, you know, it's a very different kind of a situation that we're talking about here. You know, are we going to end up with the situations in Liberia? No. But we do need to respect the risks, and we need to worry about what happens when there is a respiratory infection that is much more difficult to be able to handle and contain. Ebola is containable, but what next?
Yeah, just, you know, we have seen over and over again, Ebola has been stopped in countries with far less financial resources than we have throughout Africa. And certainly, as Annie said, we could stop it here. I think the concern, going to what you said, Chris, around the fear, is that sometimes fear creates reactions that are not necessarily the best solution. And so I think that's the concern around the fear. I understand the fear, but one of the concerns that we have is that what do you do with that fear? You know, we should be channeling our energies to stopping it at its source. I mean, that's where the fire is raging, and that's where we should be channeling our energies. And when we channel them other places, it just becomes a diversion. And so, you know, fear is useful when it's channeled, when the efforts and the actions are channeled in the right direction. It's harmful when they are not.
Well said. Let's take another question right here.
What are the most effective treatment protocols here?
So the question is, what are the most effective treatment protocols if someone has Ebola? Should I address that? No.
Well, I think, first of all, again, we have no specific medicines and we have no specific vaccines at the moment. But there is some promising efforts that are being done. Canada, for example, has sent, I think, 800 doses of experimental vaccine to West Africa. There have been some antibody type drugs, ZMapp. It is not, they're not really very much of it. And the problem is it's trying to see, is it effective? Because in a sense you want to actually do some controlled trials, but that's very difficult in a situation like this. There's also the possibility of sera from someone who's a recovered Ebola patient. It's still not clear exactly how effective or not that is. Annie may have some other thoughts.
But what we're seeing is for the patients that have gotten into high-quality hospitals
Correct.
early in the diagnostic process, who are given what's called supportive care,
Right.
in which they're being hydrated, all of their bodily signs are being monitored very carefully, they're managing the fevers, they're managing all sorts of things. The survival rate of those patients is much, much, much higher than those that are caught later or just being treated on the floor of a hospital as opposed to into a high-quality unit.
Even
So they-
in Liberia, you know,
Right.
patients are going
So
home.
early
fully recovered
detection
when they
makes
have
a
that
difference.
supportive care.
Supportive care.
And better if you start off high, better nutritioned and things like that, too.
Well, I agree with that, and I think that it's very important. I think that Leslie brought up a very important point here. I mean, if you look to see what the case fatality rate is in Liberia versus here in the United States, we've had 9 cases, 8 of which we know the outcome. We still have the doctor in New York, but out of the 8 cases we know what happened, 7 of them lived, and the only one that didn't was not able to get into treatment early on and came with who knows what his health situation was. He could have had a lot of different other comorbidities underlying that might have made him less likely to survive any infection, and we don't know the answer to that. So supportive care is of maximal importance. We are actually going to be starting a study, hopefully if our funding comes through, to be able to look at Ebola survivors and to be able to take samples from them so that we can look at their antibodies and find the antibodies, human antibodies, that are most effective in neutralizing Ebola, which would then lead to better therapeutics and vaccines. And I think that, you know, previously, given the fact that this was not as urgent, there wasn't as much funding available to do exactly that. And now those funding dollars are becoming more available, so we'll probably have better treatments soon. But supportive care is your best bet.
So I just want to say one word about why our panelists actually are able to respond right now, then give this back to Leslie. We'll take 2 more questions and then make sure our panelists stay around if people have even more questions they want to ask personally. This is possible to solve when there is commitment for a long time on the ground. So you heard Nancy speak about their lengthy experience there since the Civil War. That's why they can respond rapidly. Anne just spoke about the work they're going to do around serum. That's because they've been working there for a decade. They have the trust of the population. They have an infrastructure. They have great partners in the Congo. So one of the big lessons here is what is our long-term commitment? Because part of why it's so expensive now is how much was withdrawn before and how low that commitment had gotten.
Let's go over to Wes Nichols for another question.
Yeah, hi, I'm Wes Nichols. One question I have is related to the political environment, highly politicized environment, along with the wall-to-wall profit-centric news cycles that we all are exposed to all the time. When and if this ever becomes an American-to-American transmission, like the nurse flying to Cleveland and hanging out at a bridal salon, or the guy bowling in Brooklyn, you know, when that first one happens, I think the game really changes. And I mean, from a PR, news, and fear cycle standpoint, how do we get ahead of that? I mean, I know they're going to be better cared for. I know that the odds are much better. But as soon as, you know, people are going to be questioning, how logical is it to not actually ask these people maybe not to get on a plane for 21 days? Or maybe just hang out at their house, or the Nancy Snyderman maybe not go for pickup, you know, carry out in Jersey.
Yeah.
You know, I mean, she's going to lose her job for that. I mean, there's that in this politicized culture. I just wonder, is there much thought going into this?
Well, it's unfortunate that it's so politicized. I mean, you know, the best thing to do is listen to the science, truly, That's unfortunate. I mean, we just have to, at this point, do our best not to politicize this. I mean, it's the worst thing we could be doing with a public health issue of this kind. And so I guess what we have to do is, the hope is that some of, the fear is settled and calmed, and that calm minds will prevail, and that the calm minds will be based more on the science and what makes sense, and be balancing, how extreme should, the measures be, what's prudent, what's best. Not all the health experts agree, of course, but there is, a way of doing this with a little bit more balance, primarily because if the people who are getting on planes and going to West Africa do not believe it to be medically necessary, they will be, as I mentioned before, less likely to get on that plane because they don't view it as part of the sacrifice that they should make, and it could impact on efforts in West Africa. We hope it doesn't, by the way. I mean, there's a lot of moving parts, a lot of moving pieces, and we're still planning to scale up just like we were a week ago. But, it is a concern that's going to be harder to do that. And so I think that, whatever we do, we have to get the politics out of it and calm some of the fear, and then take a rational, more measured approach that I hope over time is reasonable and more measured.
Well said. Russ Foster, please.
This is an observation, not a question. I think this panel and the information that you've conveyed to us today is really invaluable. And one area that I think the CDC and the Public Health Service and the media has really fallen down on is education.
Right.
I think part of the answer to your question is we as a population become more aware of the facts about all this, as you shared today. There's going to be less hysteria and less political machination.
I agree entirely, and my colleague Lisa Sweetingham is sitting here, and we just published a piece in the Huffington Post earlier in the week with very practical, reasonable guidance for people like us, not healthcare workers, not people going to West Africa, to take control and minimize risk with very simple things that people can do. It's not complicated, and I think one of the real tragedies of this is that the government has lost the credible position in providing the leadership that it needs to take the concern about it and make it and convert that concern into concrete, rational action. And as a result, there's undifferentiated fear. And the reason that we put this together is to change that dynamic.
Have we identified a specifically trained hospital in Los Angeles or even California to deal just in case?
Yes, there are hospitals being identified both in the state as well as there are hospitals identified here in Los Angeles County.
Including UCLA's Ronald Reagan Hospital. And before we close, I just first want to recognize and thank Russ Fawcett, who just spoke. Our ability to work in the Congo is really very deeply related to his generosity, his insight, and his commitment to these issues over the long term. Part of what we saw at the World Health Organization and elsewhere was when people weren't seeing the fires, withdrawal of support. And so a delayed response, we heard there were many reasons, but one of the reasons was there was no one to respond. So that long-term commitment on all of our parts makes a huge difference. The awareness, the response that we have to bring together is part of why we're so thrilled really to bring these two groups, business leaders, civil society leaders, and public health leaders together so we can prevent this in the future. So thank you for coming, and thank our panelists for all they're doing, and Leslie for kicking this off for all of us.
One last comment. This is a dialogue, this is a conversation. So as this evolves, if you have questions and concerns, most of you know how to reach me, ping me, okay? And if this thing does end up getting hotter, if the numbers do get higher, if the guidance changes, we'll come back with information, we'll convene another session, and we'll give you the same kind of quality of information and guidance that this tremendous group does. Thank you, Dean Hyman, for doing this. Thank you all.